Okay, here we go. Varcarolis, whatever his name is. Number 2, Chapter 2. Every professional discipline, from math and science to philosophy and psychology, bases its work and beliefs on theories. Most of these theories can best be described as explanations, hypotheses, or hunches, rather than testable facts. For students, the word theory may conjure up some dry conceptual images, vaguely recalling the physicist's theory of relativity or the geologist's plate tectonics. However, compared to most other theories, psychological theories are filled with familiar concepts, since terms from psychological theories have filtered their way into parts of mainstream thinking and speech. We all recognize advertisements that use behaviorist ploy of thinking a gorgeous, seductive woman to the family-style utilitarian minivan. And who has not attributed language mistakes to subconscious motivation? As the fictional king greets his queen, "Good morning, my beheaded, I mean my beloved," we comprehend the Freudian slip. Whew, this is some BS here. Dealing with other people is one of the most universally anxiety-provoking activities we face, and psychological theories provide us with plausible explanations for perplexing behavior. Maybe the guy at the front desk who never greets you in the morning does not really despise you. Maybe he has an inferiority complex. Oh Lord, sorry. Because his mother was cold and his father was absent from the home. In much the same way, our patients challenge us to understand stories that are complex and always unique. We do well to have a broad base of knowledge about personality development, human needs, and the ingredients of mental health, contributing factors to mental illness, and the importance of relationships. Oh boy, this is some crap. This chapter will provide you with snapshot views of some of the most influential psychological theories. It will also provide an overview of the treatment or therapy they inspired and the contributions they have made to our practice of psychiatric mental health nursing. We begin our theoretical journey with a look at Sigmund Frood, often referred to as the father of psychoanalysis. We travel on to Erik Erikson and Henry Stack Sullivan, who initially were devotees of Frood, but found Freudian theory lacking and so took a divergent path. We will then focus on the theory of the mother of psychiatry, Hildegard Peplau, then Abraham Maslow, a representative theorist from the humanistic approach to psychiatry. We continue on with a look at Ivan Pavlov, John B. Watson, and B.F. Skinner, that bastard, as representatives of the behaviorist approach. As we near the final leg of this trip, we will explore the two dominant approaches. Haven't we already taken this class? Dominant, blah, 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 blah. We are not even going to read this. We're moving on to the next. You can read the psychoanalytic theories and therapies if you want. All right. Excuse me. All right, we'll read the psychoanalytic theories and therapies. Sigmund Freud's psychoanalytic theory. Sigmund Frood, 1856 to 1939, an Austrian neurologist, revolutionized thinking about mental health disorders with his groundbreaking theory of personality structure. Levels of awareness, anxiety, the role of defense mechanisms, and the stages of psychosexual development. Originally, he was searching for biological treatments for psychological disturbances and even experimented with using cocaine as medication. He soon abandoned the physiological approach and focused on psychological treatments. Frood came to believe that the vast majority of mental disorders were due to unresolved issues that originated in childhood. He arrived at this conclusion through his experiences treating people with hysteria, individuals who were suffering physical symptoms despite the absence of an apparent physiological cause. As part of his treatment, Frood initially sorry, I'll stop saying Frood. Oh my God, I apologize. I'm very sorry. As part of his treatment, Freud initially used hypnosis, but this provided mixed therapeutic results. He then changed his approach to talk therapy, known as the Cathartic Method. Today we refer to catharsis as getting things off our chests. Talk therapy evolved to include free association, which requires full and honest disclosure of thoughts and feelings as they come to mind. Freud concluded that talking about different emotional issues had the potential to heal the wounds causing mental illness. Viewing the success of these therapeutic approaches led Freud to construct his psychoanalytic theory, levels of awareness. Through the use of talk therapy and free association, Freud came to believe that there were three levels of psychological awareness in operation. He offered a topographic theory of how the mind functions, a description, if you will, of the landscape of the mind. He used the image of an iceberg to describe these levels of awareness. Figure 2.1. Conscious. Freud described the conscious part of the mind as the tip of the iceberg. It contains all the material a person is aware of at any one time, including perceptions, memories, thoughts, fantasies, and feelings. Preconscious. Just below the surface of awareness is the preconscious, which contains material that can be retrieved rather easily through conscious effect. Unconscious. The unconscious included all repressed memories, passions, and unacceptable urges lying deep below the surface. It is believed that the memories and emotions associated with trauma are often placed in the unconscious because the individual finds it too painful to deal with them. The unconscious exerts a powerful yet unseen effect on the conscious thoughts and feelings of the individual. The individual is usually unable to retrieve unconscious material without the assistance of a trained therapist. However, with this assistance, unconscious material can be brought into conscious awareness. Personality structure. Freud delineated three major and distinct but interactive systems of the personality: the id, the ego, and the superego. Figure 2.1 shows a picture of the mind as an iceberg. Id. At birth, we are all id. The id is the source of all drives, instincts, reflexes, needs, genetic inheritance, and capacity to respond, as well as all the wishes that motivate us. The id cannot tolerate frustration and seeks to discharge tension and return to a more comfortable level of energy. The id lacks the ability to problem solve. It is not logical and operates according to the pleasure principle. A hungry, screaming infant is the perfect example of id. Ego. Ego develops because the needs, wishes, and demands of the id cannot be satisfactorily met through primary processes and reflex action. The ego, which emerges in the 4th or 5th month of life, is The problem solver and reality tester, it is able to differentiate subjective experience, memory images, and objective reality, and attempts to negotiate a solution with the outside world. Ego follows the reality principle, which says to the id, you have to delay gratification for now, buddy, and then sets a course of action. For example, excuse me, a hungry man feels tension arising from the id. His ego allows him not only to think about his hunger, but to plan where he can eat and to seek that destination. This process is known as reality testing, because the individual is factoring in reality to implement a plan to decrease tension. Ooh, boy, that's crazy. All right, on to the super ego. The superego, the last portion of the personality to develop, represents the moral component of personality. The superego consists of the conscience, all the should nots internalized from parents, and the ego ideal, all the shoulds internalized from parents. The superego represents the ideal rather than the real. It seeks perfection, as opposed to seeking pleasure or engaging reason. In a mature and well-adjusted individual, the three systems of the personality, the id, the ego, and the superego, work together as a team under the administrative leadership of the ego. If the id is too powerful, the person will lack control over impulses. If the superego is too powerful, the person may be self-critical and suffer from feelings of inferiority. Well, that makes a lot of sense. I'll go for that. That's okay. Defense mechanisms and anxiety. Frood believed that anxiety is an inevitable part of living. The environment in which we live presents dangers and insecurities, threats and satisfactions. It can produce pain and increase tension, or produce pleasure and decrease pain and increase tension, or produce pleasure and decrease tension. Oh, or a bunch of those things. The ego develops defenses or defense mechanisms to ward off anxiety by preventing conscious awareness of threatening feelings. The defense mechanisms share two common features. One, they all accept suppression. They all accept suppression, operate on an unconscious level, and we are not aware of their operation. Two, they deny, falsify, or distort reality to make it less threatening. Although we cannot survive without defense mechanisms, it is possible for our defense mechanisms to distort reality to such a degree that we experience difficulty with healthy adjustment and personal growth. Chapter 12 offers further discussion of defense mechanisms. Oh boy, it's getting deep. Psychosexual stages of development. Freud believed that human development proceeds through 5 stages, from infancy to adult. His main focus, however, was on events that occur during the 5 years of life. From Freud's perspective, experiences during the early stages determine an individual's lifetime adjustment patterns and personality traits. In fact, Freud thought that personality was formed by the time the child entered school, and that subsequent growth consisted of elaborating on this basic structure. Freud's psychosexual stages of development are presented in Table 2.1. Can't wait. Implications for psychiatric mental health nursing. Freud's theory was relevant to psychiatric mental health nursing. Has relevance to psychiatric mental health nursing practice at many junctures. First, the theory offers a comprehensive explanation of complex human processes and suggests that the formation of a patient's personality is influenced by many diverse sources rooted in past events. Freud's theory of the unconscious is particularly valuable as a baseline for considering the complexity of human behavior. By considering conscious and unconscious influences, a nurse can identify and begin to think about the root causes of patient suffering. Freud emphasized the importance of individual talk sessions characterized by attentive listening with a focus on underlying themes as an important tool of healing in psychiatric care. Table 2.1 Freud's psychosexual stages of development. And yeah, you're going to have to look at that. Classic psychoanalysis. Classic psychoanalysis, as developed by Sigmund Frood, is seldom used today, and that's why we just talked about it for 10 hours. Freud's premise that all mental illness is caused by early intrapsychic conflict is no longer widely thought to be valid, and such therapy requires an unrealistically lengthy period of treatment, making it prohibitively expensive for most. However, there are two concepts from classic psychoanalysis that are important for all psychiatric nurses to know: transference and countertransference. Alright, these are the good ones. This is what you gotta know. Transference develops when the patient experiences feelings toward the nurse or therapist that were originally held toward significant others in his or her life. When transference occurs, these feelings become available for exploration with the patient. Such exploration helps the patient to better understand certain feelings and behaviors. Okay. Countertransference is the healthcare worker's unconscious personal response to the patient. For instance, if the patient reminds you of someone you do not like, you may unconsciously react as if the patient were that individual. Countertransference underscores the importance of maintaining self-awareness and seeking supervisory guidance as therapeutic relationships progress. Chapter 19 talks more about countertransference and the nurse-patient relationship. Don't get too attached. Psychodynamic theory. Psychodynamic theory follows the psychoanalytic model of using many of the tools of psychoanalysis, such as free association, dream analysis, transference, and countertransference. However, the therapist has increased involvement and interacts with the patient more freely than in traditional psychoanalysis. Also, the therapy is oriented more to the here and now and makes less of an attempt to reconstruct the developmental origins of conflicts. Psychodynamic theory tends to last longer than other common therapeutic modalities and may extend for more than 20 sessions. The best candidates for brief psychotherapy are relatively healthy and well-functioning individuals, sometimes referred to as the worried well, who have a clearly circumscribed area of difficulty and are intelligent, psychologically minded, and well motivated for change. Patients with psychosis, severe depression, borderline personality disorders, and severe character disorders often are appropriate candidates for this type of treatment. Supportive therapies, which are within the scope of practice of the basic level psychiatric nurse, are useful for these patients. A variety of supportive therapies are described in chapters concerning special disorders. See chapter 12 to 22. Okay. At the start of treatment, The patient and therapist agree on what the focus will be and concentrate their work on that focus. Sessions are held weekly, and the total number of sessions to be held is determined at the outset of therapy. There is a rapid back and forth pattern between patient and therapist, with both participating actively. The therapist intervenes constantly to keep the therapy on track, either by redirecting the patient's attention or by interpreting deviations from the focus to the patient. Brief therapies share the following common elements. Assessment tends to be rapid and early. Clear expectations are established for time-limited therapy with improvement demonstrated within a small number of sessions. Goals are concrete and focus on improving the patient's worst symptoms, improving coping skills, and helping the patient understand what is going on in his or her life. Interpretations are directed toward present life circumstances and patient behavior rather than toward the historical significance of feelings. There is a general understanding that the psychotherapy does not cure, but that it can help troubled individuals learn to better deal with life's inevitable stressors. Erik Erikson's ego theory. Okay, I'm going to Erik Erikson. 1902 to 1994. Erik Erikson lived, an American psychoanalyst who was a follower of Freud. However, Erikson believed that Freudian theory was restrictive and negative in its approach. He also stressed that an individual's development is influenced by more than the limited mother-child-father triangle, that culture and society exert significant influence on personality. According to Erikson, personality was not set in stone at age 5, as Freud suggested, but continued to develop throughout the lifespan. Erikson described development as occurring in 8 predetermined and consecutive life stages. You can study those because they really suck. Okay. Implications of psychiatric mental health nursing. Nurses use Erikson's developmental model as an important part of patient assessment. Analysis of behavior patterns using Erikson's framework can identify age-appropriate or arrested development of normal interpersonal skills. A developmental framework helps the nurse know what types of interventions are most likely to be effective. For example, children in Erikson's initiative versus guilt stage of the development respond best if they actively participate and ask questions. Older adults respond to a life review strategy that focuses on the integrity of their life as a tapestry of experience. In the therapeutic encounter, individual responsibility and capacity for improving one's functioning are addressed. Treatment approaches and interventions can be tailored to the patient's developmental level. Interpersonal theories and therapies. Oh, we've gone way too far. Sorry. Interpersonal Theories and Therapies. Harry Stack Sullivan's Interpersonal Theory. Harry Stack Sullivan, 1892 to 1949, an American-born psychiatrist, initially approached patients with the Freudian framework, but he became frustrated by dealing with what he considered unseen and private mental processes within the individual. He turned his attention to interpersonal processes that could be observed in a social framework. Sullivan defined personality as behavior that can be observed within the interpersonal relationships. This premise led to the development of his interpersonal theory. According to Sullivan, the purpose of all behavior is to get needs met through interpersonal interactions and to decrease or avoid anxiety. He defined anxiety as any painful feeling or emotion that arises from social insecurity or prevents biological needs from being satisfied. Sullivan coined the term security operations to describe measures the individual employs to reduce anxiety and enhance security. Collectively, all of the security operations an individual uses to defend against anxiety and ensure self-esteem make up the self system. There are many parallels between Sullivan's notion of security operations and Freud's concepts of defense mechanisms. Both are processes of which we are unaware, and both are ways in which we reduce anxiety. However, Freud's defense mechanism of repression is an intrapsychic activity, whereas Sullivan's security operations are interpersonal relationship activities that can be observed. Implications for psychiatric mental health nursing. Sullivan's theory is the foundation for Hildegard Ploughs' nursing theory of interpersonal relationships that we examine later in this chapter. Sullivan believed that therapy should educate patients and assist them in gaining personal insight. Sullivan first used the term participant observer, which underscores that professional helpers cannot be isolated from the therapeutic situation if they are to be effective. Sullivan would insist that the nurse interact with the patient as an authentic human being. Mutuality, respect for the patient, unconditional acceptance, and empathy, which are considered essential aspects of modern therapeutic relationships, were important aspects of Sullivan's theory of interpersonal therapy. Sullivan also demonstrated that a psychotherapeutic environment characterized by an accepting atmosphere that provided numerous opportunities for practicing interpersonal skills and developing relationships is an invaluable treatment tool. Good psychotherapy, family therapy, and educational and skill training programs, as well as unstructured periods, can be incorporated into the design of psychotherapeutic environment to facilitate healthy interactions. This method is used today in virtually all residential and day hospital settings. Interpersonal psychotherapy. Interpersonal psychotherapy is an effective short-term therapy derived from the school of psychiatry that originated with Adolf Meyer and Harry Slack Sullivan. The assumption is that psychiatric disorders are influenced by interpersonal interactions and the social context. The goal of interpersonal psychotherapy is to reduce or eliminate psychiatric symptoms, particularly depression, by improving interpersonal functioning and satisfaction with social relationships. Interpersonal psychotherapy has proved successful in the treatment of depression. Treatment is predicted on the notion that disturbances in important interpersonal relationships or a deficit in one's capacity to form those relationships can play a role in initiating or maintaining clinical depression. In interpersonal psychotherapy, the therapist identifies the nature of the problem to be resolved and then selects strategies consistent with that problem area. 4 types of problem areas have been identified. 1. Grief, complicated bereavement following the death or loss of a loved one. 2. Role disputes, conflicts with a significant other. 3. Role transition, problematic change in life, status, or social or vocational role. 4. Interpersonal deficit, an inability to initiate or sustain close relationships. Hildegard Ploughs' theory of interpersonal relationships in nursing. Hildegard Ploughs, 1909 to 1999, Influenced by the work of Sullivan and learning theory, developed the first systematic theoretical framework for psychiatric nursing in her groundbreaking book, Interpersonal Relations in Nursing, 1952. Ploughs not only established the foundation for the professional practice of psychiatric nursing, but also continued to enrich psychiatric nursing theory and work for the advancement of nursing practice throughout her career. Ploughs was the first nurse to identify psychiatric mental health nursing both as an essential element of general nursing and as a specialty area that embraces specific governing principles. She was also the first nurse theorist to describe the nurse-patient relationship as the foundation of nursing practice. In shifting the focus from what nurses do to patients to what nurses do with patients, engineered a major paradigm shift from a model focused on medical treatments to an interpersonal relational model of nursing practice. She viewed nursing as an educative instrument designed to help individuals and communities use their capacities in living more productively. Her theory is mainly concerned with their healthcare status and well-being. She believed that illness offered a unique opportunity for experiential learning, personal growth, and improved coping strategies, that psychiatric nurses play a unique role in facilitating this growth. Ploughs identified stages of the nurse-patient relationship, see Chapter 9, and also used the technique of process recording to help her students hone their communication and relationship skills, see Table 10.4. The skills of the psychiatric nurse include observation, interpretation, and intervention. The nurse observes and listens to the patient, developing impressions about the meaning of the patient's situation. By employing this process, the nurse is able to view the patient as a unique individual. The nurse's inferences are then validated with the patient for accuracy. Ploughs proposed an approach in which nurses are both participants and observers in therapeutic conversations. She believed it was essential for nurses to observe the behavior not only of the patient but also of themselves. This self-awareness on the part of the nurse is essential in keeping the focus on the patient, as well as keeping the social and personal needs of the nurse out of the nurse-patient conversation. Ploughs spent a lifetime illuminating the science and art of professional nursing practice, and her work has had a profound effect on the nursing profession, nursing science, and the clinical practice of psychiatric nursing. The art component of nursing consists of the care, compassion, and advocacy nurses provide to enhance patient comfort and well-being. The science component of nursing involves the application of knowledge to understand a broad range of human problems and psychosocial phenomena, intervening to relieve patients' suffering and promote growth. In her works, Ploughs constantly reminds nurses to care for the person as well as the illness, and think exclusively of patients as persons. Implications for psychiatric mental health nursing. Perhaps Ploughs' most universal contribution to the everyday practice of psychiatric mental health nursing is her application of Sullivan's theory of anxiety to nursing practice. She described the effects of different levels of anxiety, mild, moderate, severe, and panic, on perception and learning. She promoted interventions to lower anxiety with the aim of improving patients' abilities to think and function at more satisfactory levels. More on the application of Ploughs' theory of anxiety and interventions is presented in Chapter 12. Table 2.3 lists selected nursing theorists and summarizes their major contributions and the impact of these contributions on psychiatric nursing, mental health nursing, behavioral theories, and therapies. Behavioral theories are developed as a protest response to Freud's assumption that a person's destiny was carved in stone at a very early age. Behaviorists have no concern with inner conflicts, but argue that personality simply consists of learned behaviors. Consequently, personality becomes synonymous with behavior. If behavior changes, so does the personality. The development of behavioral models began in the 19th century as a result of Ivan Pavlov's laboratory work with dogs. It continued into the 20th century with John B. Watson's application of these models to shape behavior and B.F. Skinner's research on rat behavior. These behavioral theorists developed systematic learning principles that could be applied to humans. Behavioral models emphasize the ways in which observable behavioral responses are learned and can be modified in a particular environment. Pavlov's, Watson's, and Skinner's models focus on the belief that behavior can be influenced through a process referred to as conditioning. Conditioning involves pairing a behavior with a condition that reinforces or diminishes the behavior's occurrence. All right, going from 39 to 41. Humanistic theories. In the 1950s, humanistic theories arose as a protest against both the behavioral and psychoanalytic schools, which were thought to be pessimistic, deterministic, and dehumanizing. Humanistic theories focus on human potential and free will to choose life patterns that are supportive of personal growth. Humanistic frameworks emphasize a person's capacity for self-actualization. This approach focuses on understanding the patient's perspective as she or he subjectively experiences it. There are a number of humanistic theories. Our journey will stop to explore Abraham Maslow and his theory of self-actualization. Abraham Maslow's humanistic psychology theory. Abraham Maslow, 1908 to 1970, considered the father of humanistic psychology, introduced the concept of a self-actualized personality associated with high productivity and enjoyment of life. He criticized psychology for focusing too intently on humanity's frailties and not enough on its strengths. Maslow contended that the focus of psychology must go beyond experiences of hate, pain, misery, guilt, and conflict to include love, compassion, happiness, exhilaration, and well-being. Hierarchy of needs. Maslow's conceptualized human motivation as a hierarchy of dynamic processes or needs that are critical for the development of all humans. Central to his theory is the assumption that humans are active rather than passive participants in life, striving for self-actualization. Maslow focused on human need fulfillment, which he categorized into 6 incremental stages, beginning with physiological survival needs and ending with self-transcendent needs. The hierarchy of needs is conceptualized as a pyramid, with the strongest, most fundamental needs placed on the lower levels. The higher levels, the more distinctly human needs, occupy the top sections of the pyramid. When the lower level needs are met, higher needs are able to emerge. Figure 2.5 is a depiction of Maslow's hierarchy of needs as a pyramid. Physiological needs. The most basic needs are the physiological drives, needing food, oxygen, water, sleep, sex, and a constant body temperature. If all needs were deprived, this level would take priority over the rest. Safety needs. Once physiological needs are met, safety needs emerge. They include security, protection, freedom from fear, anxiety, chaos, and the need for law, order, and limits. Adults in a stable society usually feel safe, but they may feel threatened by debt, job insecurity, or lack of insurance. It is during times of crisis, such as war, disasters, assaults, and social breakdown, that safety needs really take precedence. Children who are more vulnerable and dependent respond far more readily and intensely to safety threats. Belongingness and love needs. Excuse me. People have a need for intimate relationships, love, affection, and belonging, and will seek to overcome feelings of aloneness and alienation. Maslow stresses the importance of having a family and a home and being part of identifiable groups. Esteem needs. People need to have a high self-regard and have it reflected to them from others. If self-esteem needs are met, we feel confident, valued, and valuable. When self-esteem is compromised, we feel inferior, worthless, and helpless. Self-actualization. We are preset to strive to be everything we are capable of becoming. Maslow said, "What a man can be, he must be." What we are capable of becoming is highly individual. An artist must paint, a writer must write, and a healer must heal. The drive to satisfy this need is felt as a sort of restlessness, a sense that something is missing. It is up to each person to choose a path that will bring about inner peace and fulfillment. Although Maslow's early work included only 5 levels of needs, he later took into account 2 additional factors. 1, cognitive needs, the desire to know and understand, and 2, the aesthetic needs. He describes the acquisition of knowledge, our first priority, and the need to understand, our second priority, as being hardwired and essential. He identified the aesthetic need for beauty and symmetry as universal. How else, after all, do we explain the impulse to straighten a crooked picture? Maslow based his theory on the results of clinical investigations of people who represented self-actualized individuals who moved in the direction of achieving and reaching their highest potentials. Among those Maslow chose to investigate were historical figures such as Abraham Lincoln, Thomas Jefferson, Harriet Tubman, Walt Whitman, Beethoven, William James, and Franklin D. Roosevelt, as well as others like Albert Einstein, Eleanor Roosevelt, and Albert Schweitzer, who were living at the time they were studied. This investigation led Maslow to identify some basic personality characteristics that distinguish self-actualizing people from those who might be called ordinary. Box 2.2. Box 2.2. Some characteristics of self-actualized persons. Accurate perception of reality, not defensive in their perceptions of the world. Acceptance of themselves, others, and nature. Spontaneity, simplicity, and naturalness. Self-actualized individuals, SAs, do not live programmed lives. Problem-centered rather than self-centered orientation. Possibly the most important characteristic. SAs have a sense of a mission to which they dedicate their lives. Enjoyment of privacy and detachment. Pleasure in being alone. Ability to reflect on events. Freshness of appreciation. SAs don't take life for granted. Mystical or peak experiences. A peak experience is a moment of intense ecstasy similar to a religious or mystical experience during which the self is transcended. More recently, Mihaly some really weird Russian name, developed the term flow experience to describe times when people become so totally involved in what they are doing that they lose all sense of time and awareness of self. Active social interest. An unhostile sense of humor. Democratic character structure. SAs display little racial, religious, or social prejudice. Creativity, especially in managing their lives. Resistance to conformity. Enculturation. SAs are autonomous, independent, and self-sufficient. Next box is implications for psychiatric mental health nursing. The value of Maslow's model in nursing practice is twofold. First, an emphasis on human potential and the patient's strengths is key to successful nurse-patient relationships. Second, the model helps establish what is most important in the sequencing of nursing actions in the nurse-patient relationship. For example, to collect any but the most essential information when a patient is struggling with drug withdrawal is inappropriate. Follow Maslow's model as a way of prioritizing actions. The nurse meets the patient's physiological need for stable vital signs and pain relief before collecting general information for a nurse database. Biological Theories and Therapies. The Advent of Psychopharmacology. Woohoo. In 1950, a French drug firm synthesized chlorpromazine, a powerful antipsychotic medication, and psychiatry experienced a revolution. The advent of psychopharmacology presented a direct challenge to psychodynamic approaches to mental illness. The dramatic experience of observing patients freed from the bondage of psychosis and mania by powerful drugs such as chlorpromazine and lithium left witnesses convinced of the critical role of the brain in psychiatric illness. In fact, President George H.W. Bush declared the 1990s the decade of the brain, and vast amounts of research monies and effort were directed at study of the structure and functions of the brain. Since the discovery of chlorpromazine, many other medications have proven effective in controlling psychosis, mania, depression, and anxiety. These medications greatly reduce the need for hospitalization and dramatically improve the lives of people suffering with serious psychiatric difficulties. Today we know that psychoactive medications exert differential effects on different neurotransmitters and help restore brain function, allowing patients with mental illness to continue living productive lives with greater satisfaction and far less emotional pain. The biological model. A biological model of mental illness focuses on neurological, chemical, biological, and genetic issues and seeks to understand how the body and brain interact to create emotions, memories, and perceptual experiences. A biological perspective views abnormal behavior as part of a disease process or a defect and seeks to stop or alter it. The biological model locates the illness or disease in the body, usually in the limbic system of the brain and the synapse receptor sites of the central nervous system, and targets the site of the illness using physical interventions such as drugs, diet, or surgery. The recognition that psychiatric illnesses are as physical in origin as diabetes and coronary heart disease serves to decrease the stigma surrounding them. Just as someone with diabetes or heart disease cannot be held responsible for their illness, patients with schizophrenia or bipolar affective disorder are no more to blame. It often happens that one of the most helpful things we can tell those whose lives are affected by psychiatric illness is that they are not responsible or to blame. Implications for psychiatric mental health nursing. Historically, psychiatric mental health nurses also have attended to the physical needs of psychiatric patients. Nurses administer medications, monitor sleep, activity, nutrition, hydration, elimination, and other functions, and prepare patients for somatic therapies, such as electroconvulsive therapy. They have continued to do so with the advancement of the biological model, which has not altered the basic nursing strategies, focusing on the qualities of a therapeutic relationship, understanding the patient's perspective, and communicating in a way that facilitates the patient's recovery. One of the risks in adopting a biological model to the exclusion of all other theoretical perspectives is that such a theory ignores the myriad other influences, including social, environmental, cultural, economic, spiritual, and educational factors that play a role in the development and treatment of mental illness. Additional therapies. Milieu therapy. In 1948, Bruno Bettelheim coined the term milieu therapy to describe his use of the total environment to treat disturbed children. Bettelheim created a comfortable, secure environment, or milieu, in which psychotic children were helped to form a new world. Staff members were trained to provide 24-hour support and understanding for each child on an individual basis. In 1953, Maxwell Jones in Great Britain wrote the book The Therapeutic Community. This book both laid the groundwork for the milieu therapy movement in the United States and defined the nurse's role in this therapy. Milieu is sometimes a difficult concept to grasp. It is an all-inclusive term that recognizes the people, setting, structure, and emotional climate as all important to healing. Milieu therapy takes naturally occurring events in the environment and uses them as rich learning opportunities for patients. There are certain basic characteristics of milieu therapy, regardless of whether the setting involves treatment of psychotic children, patients in psychiatric hospital, drug abusers in a residential treatment center, or psychiatric patients in a day hospital. Milieu therapy, or a therapeutic community, has as its locus a living, learning, or working environment. Such therapy may be based on any number of therapeutic modalities, from structured behavioral therapy to spontaneous, humanistic-oriented approaches. Implications for psychiatric mental health nursing. Milieu therapy is a basic intervention in nursing practice. Nurses are constantly involved in the assessment and provision of safe and effective milieus for their patients. Common examples include providing a safe environment for the suicidal patient or a patient with cognitive disorder like Alzheimer's disease, referring abused women to safe houses, and advocating for children suspected of being abused in their home environments. You will be introduced to other therapeutic approaches later in the book. Crisis intervention, see Chapter 23, is an approach you will find useful not only in psychiatric mental health nursing, but also in other nursing specialties. Group therapy, see Chapter 34, and family intervention, see Chapter 35, which are appropriate for the basic level practitioner, will also be discussed. Table 2.6 lists additional theorists whose contributions influence psychiatric mental health nursing.